A 54-year-old self-identified Hispanic man and office administrator is admitted to the hospital due to a 5-day history of progressive fever, productive cough with thick sputum, and right-sided pleuritic chest pain. So I'm just going to go ahead and highlight that. He has a history of type 2 diabetes, complicated by peripheral neuropathy and chronic kidney disease, stage 3. His home diabetes medications include metformin and glipizide. I'm just going to go ahead and highlight these important risk factors here. He admits to poor compliance, noting that his home fingerstick glucose levels have consistently remained above 250. He has no history of tobacco use, alcohol use, or recent travel. On physical exam, he appears acutely ill and lethargic. Acutely ill and lethargic. His temperature is 102, heart rate's 112, respiratory rate's 24, and his blood pressure is 108/62. All right, so he's febrile, tachycardic, tachypneic. He is clearly very ill in this moment in time. Examination of the oral cavity shows dry mucous membranes, but no dental caries or tonsillar exudates. Pulmonic examination reveals decreased breath sounds, dullness to percussion, and coarse crackles over the right middle and lower lung fields. So there's clearly some kind of a pulmonary infiltrate or consolidation finding based on that physical exam over here. And then the remainder of the physical exam is unremarkable. Lab evaluation demonstrates an elevated leukocyte count of 16,500, serum glucose of 342, and an A1C of 11.4. So now we know that his A1C is very high, and that means his diabetes is very poorly managed, which increases his risk for certain opportunistic infections. But also we know that there's clearly a lung infection going on with this elevated white count, fever, and these pulmonary exam findings. Furthermore, a chest radiograph reveals a dense lobar consolidation in the right lung with early cavitation. So early cavitation is never a good sign, and again, raises my concern that there's some kind of opportunistic infection, possibly fungal, going on here, even bacterial, but let's see. Subsequent sputum sample obtained for silver stains and histopathologic assessment demonstrated broad non-septate hyphae branching at right angles. So this silver stain and this finding of hyphae branching at right angles tells me that this is most likely the bug Mucormycosis, and mucormycosis is likely going to be implicated in patients who are poorly controlled type 2 diabetics or severely immunocompromised, and they'll likely present with this kind of a lung finding that has a cavitation. It'll have a sputum sample that shows you these right angles, and then they're going to be acutely ill and pretty quick in terms of how when it starts to when it progresses. So within 5 days, he has this cavitation in his lungs. He's very ill appearing. He's 102 fever. So these are all really bad signs, and in the context of his diabetes tells me that this is most likely going to be mucormycosis. And so something like this requires early surgical debridement and also systemic antifungal coverage. And so here it's going to ask us what's the most appropriate pharmacotherapy. And so this is just something you're going to have to remember. But for an invasive infection like this that can rapidly spread and cause very severe complications, IV amphotericin B is going to be your answer choice. For something like capsofungin, you're going to use that for something like Candida. It's not going to have as much coverage for, let's just say, something as invasive as a mucormycosis or an invasive aspergillosis, kind of a fungal infection. Oral fluconazole and nitroconazole, I think of these to cover more things like histoplasma or blastomyces. They're not going to be as useful and have enough coverage for something as invasive and as mucormycosis. And then oral voriconazole is useful in the setting of invasive aspergillosis. And so for those reasons, you're just going to have to remember that when you see this severely uncontrolled diabetic who's acutely ill, has some kind of pulmonary findings, they might even show some kind of necrotic lesion if it's somewhere in the nasal or oropharynx cavity. It requires immediate surgical debridement, and if you see these non-septate hyphae with right angles, you could pretty much be sure that's mucormycosis. And